The other thing that's really interesting is that we tend to sort of lump people into these categories. And we're like, human beings are diverse. We have all these different parts of us. So I refer to these things as the different domains of a human, right? So someone's gender identity, how you feel about yourself on the inside, is not always what you're expressing, your gender expression to the world. That confuses folks if it doesn't line up. So I always give myself as an example. I clearly have short hair and I wear t-shirts and jeans. I have been called sir, I don't know how many times. That's an assumption of my identity based on my expression. And so a lot of people do that. Now, someone's expression and identity don't always match up because it might not be safe for it to be that way. So if you have someone who identifies as female that was assigned male at birth, it might not be safe for them to go out in traditionally feminine clothing from where they live or what they're experiencing. So it's not for us to decide what's right for someone else. We're really good at trying to do that, but that's probably the last thing we should be doing in this case. So your identity and expression are separate things. What you're assigned at birth is based on your genitals. So there are intersex folks, male and female, and then who you're physically attracted to can be different from who you're emotionally attracted to. And I've learned most of this, complexity from the young people that I've worked with over the years, and them explaining to me these things. Things like this are really helpful diagrams. This is loosely based on the genderbread person and the gender unicorn, if you've ever seen those online. But this is from our About Kids Health site. So we have a teen information site. And so we created this to kind of do that. Now, if you have a non-verbal young person or someone who's so anxious that they can't articulate who they are, they can nicely put little X's in all these boxes and say, I feel this much female and this much male, and they can sort of indicate that, and it helps them explain themselves to us so we can understand. I think it's sort of a nice visual to help that. It also helps people who are new to this language and this conversation to see that all those things are different domains. I think it's important to keep that in mind too. So we mentioned the term transgender and cisgender. Pretty simply, a cisgender individual, their identity aligns, well, it's going to be fun popping in and out there, who they are on the inside aligns with what they were assigned at birth. So they're cisgender. So I was assigned female, I identify as female, therefore I'm a cisgender female. Thanks. It's that simple, eh? I always got to make things hard. And then if you have transgender folks, so if your gender identity assigned at birth doesn't match up with who you are, then you're transgender. That's a huge term, right? That catches all those other people. And interestingly, a lot of young people don't like the term transgender. They have lots of different ways of describing themselves, and that they might not embrace this language, but that's sort of what we're working with right now. When we say someone is assigned female or assigned male, that's sort of a safe way of knowing what their point of reference is. Now, we need that in healthcare because we need to know where we're starting and where we want to go as far as hormones and different treatments and things. But it's also safe and not insulting to someone because you're not saying anything about their current identity. You're saying you were assigned this at birth. So it's sort of a safe space. So my colleagues around the hospital will say, well, what do I say to, if someone's has a female body, but they identify as male and we need to do a pregnancy test before we do this x-ray or whatever. And I say, just say, because you were assigned female at birth, we need to do this test. So it doesn't have to be that complicated, right? So that's what, we try to keep it simple. And I think that's really helpful. And the young people aren't offended by that because that's a fact. They didn't choose their gender, it was assigned to them. So we say that gender is a spectrum. And I like to describe this as one of the very first non-binary identified youth that I cared for described it to me. They said, okay, so there's blue at one end, there's pink at the other, and there's really nice shade of purple in the middle, and I'm purple. I said, okay. And then they said, some days I feel a little bit more blue, and some days I feel a little bit more pink. I'm like, oh, that makes sense. I don't feel the same way every time I wake up in the morning. Sometimes I wear different things and present differently. So that sort of resonated with me. So I like to use this because a visual learner, that helps. Clearly, I don't know how to work these things, but that's good. But then I'm wondering now, maybe it looks a little bit more like this. So it's not so linear. It's, it's all kinds of stuff in between. And I think young people are describing this in different ways, the language that they use, how they describe, this part of their identity and that part of their identity. So I think we just have to keep an open mind to that. And as I mentioned, there's a lot of different cultures that have had, gender diverse folks since the beginning of time. And it was accepted as that's who they are, different systems and different religions. All right, so let's a little talk about gender identity formation. So little kids know their genders really early. So, right, little toddlers can say, I'm a boy, or I'm a girl, or I'm not a boy, I'm not a girl, however that goes. And a lot of it's based on anatomy. If they're in daycare and they have the little room with all the potties, they know who has a penis and who doesn't. They know in their house who might have a penis and not, and that's our point of reference often. So they can say that. And they're also told good boy, good girl, boys' toys, girls' toys, all those sorts of things. So they learn super early about that. So it's not a really strange concept to them. And the kids that I work with will say, I remember when I was in daycare and they said, boys go to this side of the carpet and girls go to that side of the carpet. I didn't know which side of the carpet to go to. right? So it can happen that early. Or the parents will tell me their sort of story about the gender history, and then they leave the room and the kid goes, well, actually, it was like this, right? So, so they can relate to that. So around 4 or 5, so we're thinking like JK and SK, kids have a pretty stable sense of their identity and who they are. It's not fixed, but it's pretty stable. And that's when they start to learn the gendered role behavior, right? That's when the colored of clothing, the boys section, the girls section, the toys, and what girls are supposed to do and what boys are supposed to do becomes much more apparent to them. It's everywhere. And then they're drawn to their same gendered peers. Okay, so if you think of a little 4-year-old or a 5-year-old who's assigned a male, but identifies as a girl, wants to go play with the other little girls, right? That's normal. That's a developmental thing. If those other little girls welcome that child, all's good. But if they say, you can't play with us, you're a little boy, then all of a sudden there's already a sense of other. At 4 years old, they're already thinking, what's wrong? And a lot of young people describe that to me. I knew something was different. I didn't like the things my friends liked, but I didn't know that there was a thing. I didn't know. We don't raise our kids saying, I'm going to say you're a girl, but you might be something else. So we don't raise our kids like that, right? So it takes some time sometimes to find the language, to find the words, to explain that. But in the interim, there can be a lot of turmoil, finding the word, a lot of distress. And so when a young person doesn't present to us until they're 14 or 15, and they've been dealing with this since they're 4 or 5, that's a lot of years of distress. And so that's why we can say that they have, higher rates of anxiety, depression, all those things. It makes a lot of sense when you go back in time and figure out where they've been at. Again, it changes. If they're in an affirming environment, then obviously their distress is going to be different than if they're in an unaffirming space. So now let's forward a little bit ahead to 6 and 7-year-olds, grade 1 and 2. So oftentimes they feel more secure about their identity and they stop expressing so obviously outwardly to other people. So my example is the little 4-year-old pink frilly princess, pink everything little girl. When they're 6 or 7, that might tone down a little bit because they don't have to prove that to everybody. They know who they are. This confuses parents because the parents will say, how can you be a boy? You were such a little girly girl when you were small. So again, there's that expression versus identity that filters back in, and parents' points of reference sometimes have to shift as well through time. So again, if early on they start to feel that their sex assigned at birth is different from how they feel, like a lot of them say to me, I thought I was just going to grow up and I was going to grow a penis, or I thought I was going to get older and I was going to go breasts. They don't think that there's anything different because they don't know. Or I thought everybody felt this way. I hear that a lot from young people. I thought I didn't know I was the only one. So you can see that social anxiety can start super early. Hopefully we can educate educators and parents and people early on to be more accepting. I did a series with Public Health Agency of Canada on how to be an affirming provider across the whole country with all their 0 to 6 programs, like 200 programs, and they had a lot of their staff joined. It was just like basic stuff like language and how to create safe spaces and how to not make assumptions and all those sorts of things. So that was a pretty powerful thing to do. And I had that all developed by community members. I just facilitated it. I just made them do the work and they took the glory. It's got to be something happens with age, right? Figure things out. All right. So then we start to get around, 8 and up. So we're talking grade 2-ish. Then we start to see those really stereotypic behaviors, right? The little boys play a certain way on the playground, the little girls play another way, and you can start to see that really clearly. And then puberty starts to approach, and that's when it becomes really distressing because that body that you could previously wear anything, shirtless, whatever your hair is, starts to change. And if it's a direction that you do not want, do not wish, or are afraid of, really distressing. So puberty is a very pivotal point for young people as far as their care. And it's starting earlier and earlier. We have, little assigned girls that are menstruating at 9 and 10, which means their puberty started 2 years before that with changes to their chest. So that's when you get a lot of the slouching and the hiding themselves and not wanting to be seen, and those behaviors that we can see because they're not comfortable in their own skin. And we can see it super early on. Okay, so sort of summing up the developmental stuff. So the middle childhood is that same sex or same gender peer interaction, and they want to look and act like their same gendered peers. And those gender roles are enforced everywhere, at home, in daycares, in stores, everywhere, and acting a certain way. Boys don't do that. Girls don't do that. I talked to a young person last week that was describing to me how they knew from the time they were 3 or 4, they were assigned female, and they knew that they were a boy, but they were told their entire life, little girls don't do that. Little girls don't do that, over and over again. So there was shame in their behaviors and shame in the things that they were interested in. Or I have other people that say, well, I'm female, but I'm into male things. So there's still, their points of reference are still very societally driven on the binary model. So it's really quite interesting. And we know that heterosexism is a dominant social perspective in Western culture. And so everything's a point of reference. Everything is a mom and a dad, and everything's male and female. So it's it takes a lot to get around that. So if those conflicts are happening early, that's when we start to talk about the onset of gender dysphoria. You're a busy little guy.
Yeah, this
Doesn't work, eh?
hopefully this one's better.
Yeah, we'll try. You'll let me know. I'll see you again.
There we go.
Thank you. All right. Okay. All right, here's a little exercise for us. Look at this little lovely person. Is this a little boy or a little girl? You're going to draw your conclusions. Okay. But think of all the things that influence that decision, right? If I put this child in pink, would that change your view? If I changed the doll to a truck or an action figure, would that change your view? So that's societal influence. And I say, even though I've been doing this work for almost 10 years, my brain still goes to a binary point of reference. Oh, that guy has nice shoes. Why did I have to say that guy? Why can't I say that person has nice shoes? But I'm so wired for that. So there's so much unlearning. It's the same as our dealing with racism and indigenous and all that sort of stuff. We have to unlearn all those things that we thought and assumed and sort of reframe things for ourselves. So I never tell you if it's a boy or girl because that bothered Julie though previously. So that's sort of the classic example of what we call gender nonconformity. So little boys playing with dolls. And I don't like the language of gender nonconformity because it sounds negative. So why should we conform to anything personally? So we say like gender creative or gender expansive, gender diverse, gender fabulous. You know, there are lots of different ways to describe folks like that. So that's a better way to go. So these little gender independent children are those that are behaving differently than what we expect them to behave like. Again, there's that societal point of reference. So, you know, they're not supposed to behave that way because they're a boy or they're a girl. So we see that. But there's a variety of that. Some very strongly say I'm the actually opposite, and some say I'm neither, and some say I'm a variety of those things. So it's just, you know, important. The other point that's challenging is because that story can change. So as a young person is figuring out all the things that we expect them to do in adolescence, their identity can also move around in there too. So they might start out, and often they would come to our clinic being very binary. I was assigned female, I am a boy, right? Nothing in between. And these are my pronouns and this is my name. And then over time, as they get affirmed and they feel more comfortable, they kind of move a little bit toward the middle, right? And they start to think, okay, well, maybe I'm non-binary, maybe I'm fluid, you know, and so they start to appreciate that. And that's not a usual thing that we allow young people to change their minds. We expect them to have the answers and to stick to it. And so you hear things from parents, well, last week you said this, or last month it was this name, and I can't, you know, I can't keep up. If you're going to pick a name, pick one that's going to work for you. And if you have to try on a few to get there, that's fine. I have lots of young people I've worked with that have changed their name 3 or 4 times. I just cross it off and start again. You know, so I think, if you have the privilege of doing that, you should pick a good one for sure. So talk about how prevalent is this? So this is kind of interesting. When we started our clinic in 2013, most of the literature said 0.05 to 0.1% gender diversity. I don't think we were asking the question. I think that's part of the problem. Similar to underestimating the number of, you know, lesbian and gay identified folks back in the 70s, 80s. They didn't exist. Well, yeah, they did, but they didn't have a point of reference and nobody asked them the question. So when we looked at studies, we put a paper out in CMAJ in 2019, and it was 1.2 to 4.1% of the population at that point in time. And of the kids that were in gender clinics in Canada, so transgender identified, 41% of those young people identified as non-binary. So again, not at either end of those spectrums, but somewhere in that middle space. And now more recently, they put a study out in pediatrics in 2020, and that one asked the question really nicely. They said, so what was your sex assigned at birth? And how do you identify? And they had that listed. You could see a boy, girl, trans boy, et cetera. And 9.2% of those young people said that their identity was different from what they were assigned at birth. So that incongruence was there. And I think that's probably closer to the truth if we actually ask the question in that way. Because nobody wants to be 100% anything, because I don't think that's realistic. It's like, what's an ideal? There's no like sort of an ideal. So fortunately, they finally asked this question in the census in 2021. So 100,000 people across Canada in that census identified as transgender or non-binary. So 0.3% of the population. My daughter helped me do that math. So thank you. So yeah, and look, they're across the whole country. There's gender diverse people in every province and territory. But this is so grossly underestimated, right? Not everybody filled out a census. Not everybody has a house to get the mail to fill out a census. Not everybody feels safe filling out that census. And we did not capture youth in this, right? It was asked about households. It didn't ask about people in your house. And it didn't ask at the same time they were asking about gender identity, they weren't asking about sexual orientation. So like, you can't have all of it. You can only have a little piece of data, but at least they're asking. So we'll start with that and we'll appreciate that. But I think is really underrepresented, and my colleagues in the field feel the same way. So we talked about different identities. This is not an exhaustive list, but it's a lot of different ways that young people describe themselves. You can see, you can read gender fluid, gender queer, etc. Those two terms are in the Merriam-Webster dictionary as of 2016. Pansexual is in there as of 2018, and they as a singular pronoun as of 2019. So it is in our common day language, in our lexicon, and it's been recognized by Merriam-Webster. So there you go. That's a reliable source. So yeah, but it's not exclusive. And what does that mean? Like, if someone describes a term to me and I haven't heard it, I say, what does that mean to you? I don't know that language. And that's okay to ask those questions. So it shows a curiosity and an interest if you're asking for clarity. The other nice thing when working with young people is when you start asking them to explain things, you shift that power differential, right? I'm not the boss anymore. I'm the one learning. And I think that helps them with developing therapeutic relationships, because there's a bit of a trust, because you're not acting like you know everything. You're actually trying to learn from that young person. So I think it's just important to keep that in mind. Yeah, and again, like, not an exhaustive list, and it can move around. All right. So I mentioned being affirming. So let's talk about the why first, and then the how to be affirming. And the why is a sad thing about statistics. And I could fill pages and pages of these stats about the increased risks of mental health and high-risk behaviors and all those sorts of things. We know that 2S LGBTQ youth are prone to many more of these things. Most of these studies didn't include transgender folks from at the beginning, and now they are. So a lot of them are just based on, what we call sexual or gender minority youth. But you'd see some of the, that they have an increased risk of suicide, substance use, sexual assaults, exposure to violence, experience homelessness, all those sorts of things. 40% of homeless youth are transgender or sexual minority youth. In American study had a third of them with major depressive disorder, and almost half of them met the criteria for generalized anxiety. We did a survey on our 300 youth and parents in our clinic, and similar findings. And the older they were, the higher the rates of depression and anxiety, right? Because they were dealing with that and with puberty just that much longer. And the downside of this is that now I have a 2-year wait list for our clinic because the demand's so high. I can't accept a 16-year-old. I'm in a pediatric center, and they'll age out before we can see them. Upside of that is that there are more providers in the community than there were when we started this clinic 9 years ago. So I do have places where I can send folks. But these are the kids that I know are the most distressed, and they're the ones that I can't accept into the clinic. So it's hard things to sleep with. Gotta get that, your head around that. And then when we looked at Canadian transgender youth specifically, so those that are in clinics, that 70% had experienced sexual harassment. And a lot of the kids described to me, I was being bullied before I even came out, just because of how I present or how I act, because I wasn't this enough or that enough. And so, children can be cruel, and they can find reasons to pick on people. And then sometimes we give them even more fuel for that. And then when we looked at transgender youth as well, like 3/4 of them had a primary care healthcare provider, but almost half of them had unmet healthcare needs, because they're afraid to go to those primary care providers, because then they have to explain who they are, and they have to explain why they're not pregnant, and they have to explain why, all these sorts of things, and often educate their primary care providers on what they need and beg for a referral to a specialized clinic. And I've had kids as recently as 2 years ago go to a family doctor and being told, that's a sin, I don't believe in it, I'm not going to make that referral. In this day and age, like, it's just, it blows my mind what some of these kids have been through and have gone through, and families, to get to see us. So we welcome them with open arms and hopefully go from there. All right. So I turned the term gender dysphoria. Those of us working in the field are not really a big fan of that language, because it has a negative connotation, and it is in the Diagnostic and Statistic Manual of Psychiatry. I knew you was getting
One more try. A new microphone. Do it. Oops. This one.
That's the winner. Winner, chicken dinner. Yeah. All right. Should I move it a bit? Is that better? Will that work? That better? All right. Okay. I'm not usually quiet, so that's unusual. All right. So yeah, so gender dysphoria is a Diagnostic and Statistics Manual 5 psychiatric diagnosis that we don't want to use, but that's what we're working with, because in the province of Ontario, you need that diagnosis to get care and to get treatment, funding, etc. So what it basically means that there's a distress caused by that discrepancy between what you were assigned and how you identify. And that's how we describe it to our young people. You have to have had the symptoms for 6 months. We have a 2-year wait list. Check. That's easy to do. And it has to cause some distress or discrepancy. So how I describe that is that's that distress, and we need a diagnosis, and we want to lessen that distress. It is not a pathology. It is an identity. And so if we're clear about that, then young people can accept that. There is an ICD-10 code in the medical land called gender incongruence, which I think is a more acceptable language that we're working toward. Our healthcare system hasn't quite caught up to speed. That may never happen, but that's a separate conversation. Again, not all gender variant individuals have gender dysphoria, because if they're raised in affirming households and surrounded by knowledgeable affirming people, they don't have that level of distress. And I can't tell someone what their dysphoria comes from, because everybody's different. So I have assigned females who are so distressed by menstruating that they won't leave the house or go to school. And then I have others that are like, it's just the body that I have. It's not a reflection of my identity. And they're very pragmatic about it. And everything in between. It's a similar, and I compare this to frame it to trauma. I can't tell you or anybody in this room what their trauma is or what causes them trauma. Dysphoria is a similar thing. This really messes with my physician colleagues. You mean, how do you measure that? I go, you don't measure it. You mean we just take them at face value? I'm like, yeah, what a concept, right? It's not a medical thing, but that's okay. I'm not going to bash my physician colleagues too much, just a little. All right, so okay, this is fitting. That's pretty good. So WPATH is the World Professional Association for Transgender Health. And they released their 8th version of the standards of care in November. So this is the standards of care for the entire world. It's an international standards, and it's like psychologists and psychiatrists and endocrinologists all coming together. It was incredibly controversial because people didn't like this and they wanted that out. But it has to kind of speak a little bit to the middle because it's interpretable depending on where you work. So in Canada, in Ontario, we don't have an age of consent for healthcare. So if a young person has the capacity to consent to this, understand the information and consent, they can, basically drive their own bus on their healthcare. Obviously, I want parents involved because they'll do better, but I don't need them there, which is really powerful for the young person. See, I told you, right? So, but in other places, other jurisdictions, there's 18, or you have to have parental consent. There's different ages. And then now south of the border, there's a whole lot of other ugliness. So I think, that these standards of care are, very comprehensive. You can find them online. If you just Google WPATH standards of care, you'll find it. There's a whole chapter on children. There wasn't one before. And that chapter talks about being affirming, allowing social transition, and, allowing kids a place to explore. The chapter on adolescents speaks a lot about that identity exploration, like giving them that space to change their mind and move around. It talks about caregiver and parent involvement, if it's safe to do so. So if it's not safe, then, you don't include them, and that you have to have what we call a biopsychosocial assessment. So this means you do not need to see a psychiatrist before you see a gender expert. You may need a psychiatrist if you have concurrent mental health disorders, but it's not because of gender. But there are still models of care that are like that you have to do the hoop. You got to see the psychiatrist, and if you don't dress masculine enough or feminine enough, then they don't give you the tick box. The stuff that gender diverse folks have had to go through historically to get care has already been horrific, and now it's that much worse. So I think it's just recognizing that there's a lot of barriers for them. And then as far as care delivery and the things that we do in our clinic is we give that gender dysphoria diagnosis, and we might do hormonal suppression, puberty suppression, put things on pause so they can figure things out. And then we also would prescribe hormones. We don't do surgeries at sick kids, but we help, this is a good clinic and here's the form to apply for funding, and we help navigate the system, but we haven't done that per se. And then the other thing we talk about along the way is fertility for the future. So if you're talking about young people who think that they want to have biologically related children, then we would counsel them to potentially do some sort of fertility preservation before we initiate medications that may change that in the future. Less of an issue for those assigned female, because female bodies are very good at protecting ova, and they carry eggs on into the future. And there's lots of trans guys that come off their testosterone and still donate an egg or carry a pregnancy and have really good pregnancy outcomes. The other way around, though, for those assigned male, then stopping testosterone production will make them infertile because they won't be able to make viable sperm, right? So it's a little bit different. So oftentimes we try to if they're thinking of that, to do that ahead of time. Now, the majority of youth that I work with have absolutely no interest in fertility preservation. It is the potential grandparent, i.e. their parent, who is usually driving that bus. Oftentimes they will go and they have the consultation and do the counseling, and they're like, yeah, I'm not doing that. No way. We do have a number of assigned males. We do sperm banking, much more straightforward procedure than having to do egg harvesting. And when you talk to a young person who identifies as male about the process of cycle stimulation and fertility preservation and egg harvesting, they're like, yeah, no, I'm not. We tell them, we give them the information, the options, so they're making an informed consent and deciding whether they do or don't want to do that. All right. So the talk about social transition, which we've mentioned a bit. Prior to puberty, the care is just affirming care. There's no medical care until you've started puberty. So a lot of it is around social transition. So we encourage allowing that. So changing your presentation, cutting your hair, growing your hair, changing your clothing, changing your name and your pronouns at school, all those sorts of things, using the bathroom that matches with your identity. And that's actually a human right. That's not a nice thing to do. That's on the Human Rights Code in Ontario and in Canada. And we have seen that children's comfort dramatically improves when you let them socially transition. Just that alone. And you can tell lots of parents that have those stories. They say, my child was sad and angry until they told me they were a little girl. And I started calling them by that name and they just lit up. And I've seen it in our clinic, kids that are so shut down and so closed off. And when you start to affirm them, they just blossom. Some of the most rewarding work that I've done. And I've worked on, ICUs and NICUs and all the flashy dashy stuff, but this stuff's important. This is our future. These kids are our future. And if we don't take care of them, they're not going to take us and push us around in wheelchairs and all those important things. Take some notes. There we go. All right. The other point that's really important is that kids need to know that if they change their mind, it's okay. If they don't want to present as Susie or Jimmy or whatever next time, next school year or next place you go, that's okay. And giving that permission is really important. This doesn't cost anybody anything to do this. And I struggle with why some families have such a hard time. Or you can wear that at home, but you can't wear it to school. Or you can dress like that way in the house, but you can't out of the house. There's that shame again, right? That sense of it's not okay. And kids pay attention to everything we say and do. So it's really important that we frame these things. I'll give you some more tips on that in a sec. All right. So this affirming approach allows a young person to explore safely. We follow their emerging sense of self. So it's the same sort of thing. What do? You do what the kid tells you to do or asks you to do, and don't sort of impose what you think. Changing the young person is never our goal. And there's lots of literature that supports this approach and that shows long-term, lifelong improvement in mental health outcomes just from affirming someone at earlier and earlier ages. So I think that's really important to know that. So what do you do when someone you know comes out? Be affirming, validate that, say something. Don't just stand there with a gobsmacked look on your face and do nothing. Remember that, love and affection. I still love you, right? Thank you for sharing that with me. This is really important. When a kid has the courage to come forward with their identity and you shut that down, that's a bad move because they know that and they remember that. I always tell young people the first time that people's reaction, and I got this from a very wise adolescent medicine physician that I worked with years ago. People's reaction to news, their first reaction is not necessarily where they're going to land at the end of the day. It's their first reaction. So you embrace young people to do that when they're planning to disclose. What your mom says or does, or your friend or whomever, it might not be where they end up. So just give them that moment. And they're very creative in how they come out. PowerPoint presentations. I have a couple of my patients that get PowerPoints for their parents. They'll just do a random text on the way to school. Oh, by the way, email. Yeah, email. A note in mom's bag, and then mom doesn't see the note, and the kid's fretting all day long, not knowing what's going on. Backseat car, mom's driving, drop that bomb. That's a good one. Don't have to make eye contact. That helps. So there's lots of different ways you do that, but it's just really important. This is really important, and it's really personal. And I'll share some quotes from some young people as well. And just, watch your body language, right? So it's one thing, and I work with teenagers, right? So sometimes they're telling me things, my head is exploding. I'm like, oh my God. I'm like, oh, okay, well, tell me more about that. Told me a lot of things today. What's the most important thing for you? Right? So just like toning that down because they read that. Young people are assessing me as much as I'm assessing them. They're trying to see, is this a safe person? Is this a judgy person? How are they? And all those sorts of things. And avoid jumping to questions. Avoid asking about labels, because that's what we want to do. And don't make assumptions. Just because a young person says, I don't feel like a boy, I don't feel like a girl, or I am a boy, or I am a girl, doesn't mean they're going down the road with surgery and hormones. That's where the parents' heads go automatically. They're gone. They're not in the moment. They're already down the road. And you're like, okay, come back in the moment. Let's talk to the young person. Really important. And use their labels. If they say they identify as non-binary, gender fluid, that's the label that they want to use at the time. Offer support. Okay, thank you for telling me that. How can I support you? What do you need from me right now? And so really in the moment. And ask for permission to ask questions, not to ask questions. I have had so many young people lately tell me that their parents keep asking them, have you thought about this? Have you thought about that? What about this? And it undermines their confidence, right? So they were pretty sure about who they were. They bravely came forward and then they get undermined. And that's the interesting parenting strategy, but it happens often. And so sometimes we do role modeling. Okay, when they say this, what are you going to say? We do some coaching and stuff. And then ask who they're out to. They might not be out to everyone. They might be only out to the immediate family. They might be only out to school and not here, not there, and all sorts of things. And then reinforce the opposite action to shame. We don't shame someone for telling us something that personal and important, but often that's a reaction. No, that's just a phase. You're just making that up. You're only trans because those kids that you hang out with. I said, no, they were trans before and they found their people. So realigning that. So it's really important that we sort of think about those moments. And it's okay to just say, I need a minute. This is really big news. It's okay to say that. It's okay to be vulnerable and say that. Or you just tell me something really that I wasn't expecting. Just give me a second here. Right? So sort of summing up the points to consider. So identity is personal and fluid. It can move around. So again, giving that permission to move around is really important. That expression and identity don't always match up, that we talked a little bit about. So don't make those assumptions about how they should be or not. Dysphoria or distress is very personal. And the timing of social transition is also personal. So there's no rule. There's no rule that says you must socially transition before you medically transition. A lot of the older presenting trans feminine folks, so those who are assigned male, have gone through a significant amount of male puberty before they reach some care. And so many of them want to be on hormones and further down their path before they disclose to other people, because that aligns better for how they feel and they feel more safe and comfortable. Whereas everybody else says, well, you don't present like a girl, so how can you be a girl? But when they explain it to me like that, I understand that. And I keep saying there's no rule. So it's not that, but a lot of people outside of this sphere of care think that way, think that you need to cut your hair and change your clothing and change your name and then do the medical stuff. So there's no proper sequence for that. And people start and stop their care. And they might be on hormones for a period of time and stop for a while. That's not an uncommon thing, but that's not being played that way. It's being played in the media as detransitioners and all this regret. That is such a small percentage of people that we're talking about. But those are the ones that get all the bells and whistles, right? They're the ones that all the hate people glom onto and support. Right, so how do we make environments more inclusive? Just some examples. So most of our health records say male, female, or other. That's really not a very nice way to categorize someone. So now we actually have, as of this week, we have gender identity available in our electronic medical record at sick kids and pronouns. Hey, finally, it's only taken how many years? So that's a huge thing. Waiting rooms can have posters that have very binary heteronormative things. So try to make those more neutral. Statements of inclusion. We welcome everyone here. Statements like that, all genders, all races, all religions, all cultures. So make it inclusive. Washrooms, single stall bathrooms, it's the way to go. They're designing this new hospital. And, well, we need to have a meeting about how the bathroom configuration. So just make them all single stall bathrooms. They have a toilet and a sink and a change table. Okay, if you want to put a urinal, put a sign on the door that says there's a urinal. And if a lot of spaces that you go to now will have a picture on the door that has either a urinal or a stall, so you know what you're up for. And my premise is, who cares where you go? Just wash your hands. Documentation with permission, right? So not everybody wants to be out. Not everybody wants their name and their pronouns on their chart and on their documentation. So make sure that they are aware of that and you have permission to do that. So you don't want to out people unnecessarily because that could put them at risk. And then role model that. So we have, pronouns in our email signatures now. We all wear pronoun buttons. A young person said to me, if they see a care provider with a pronoun pin, they know they're safe. If they see a rainbow sticker in a waiting room, they know they're safe. It's little simple things like that don't cost a lot, that make huge statements. If you're going to say that you have a positive space, then make sure that everyone in that space is educated on how to create a positive space. So don't make assumptions that people know what that means, right? All right, how do we interact? Similar things to summarize, using their name and pronouns. And sometimes young people will say, well, you call me this in front of my mom, but call me that when we're alone. Very confusing. And some of my colleagues that work at the bedside, well, how are we supposed to manage that? I've said, you got to try to do that. But sometimes kids also do that intentionally because they want us to out them so they don't have to tell their parents, right? So there's some strategy there. They got to figure it out. Privacy is a huge thing. So making sure that the conversations that you have are private and that you have permission to share or permission to ask questions. The youth is the expert. Nobody in this room can talk about anybody else's gender identity. It's a very personal thing. And when I say to you, young person, you're the only person that can speak to this. Gender is complicated. I'm going to ask you a bunch of questions so that I understand who you are. It's not a test. There's no tick boxes. You have nothing to prove to me. I don't care what your identity is. I want to make sure you move forward in a safe and healthy manner. So and just framing that's really important. Young people will answer any question about anything personal if you tell them why you're asking, right? So if I'm talking to them about sexual activity, so, any romance? Yeah, I have a boyfriend. Oh yeah. How long you been together? 8 months. Whoa, that's really long in teenage land. Yeah. So is your boyfriend cis or trans? I want to know what body parts are involved. I'm a healthcare practitioner, right? And I say that I need to know if you're hooking up with someone, what parts are involved so I can counsel you on how to be safe. Okay, well then it's this and this and this, right? So they tell you. And then, like I said, keep in mind that they may have had really bad experiences before this, really negative. So they're going to be cautious. So they might not be very forthcoming. They might be what we call stealth and not tell anybody and not want anybody to know. And those conversations are always what happens if someone finds out, right? Because I worry about their safety. So we have those conversations as well. So we, like I said, lots of stickers and brochures and things around our clinic spaces and that, just to make people know that it's a welcoming space. All right, a little bit of literature evidence for you, because, just because I said it's a good idea doesn't mean you have to do it, but there is evidence to show. So using someone's chosen name in any context, in the context that they spoke about in this study were at school, at home, religious settings, and healthcare settings, right? That there's a 29% decrease in suicidal ideation just by using their name, and 56% decrease in suicidal behavior. So it's important. It doesn't cost us anything to call someone by their name. And it's a matter of respect. So we put this in place about 4 years ago at the hospital. So preferred name is in the chart now as the dominant name. It's on the name bands now. Wasn't before. So that was a nice big switch, but it made a huge difference. And like I said, it doesn't cost anything, but now it makes people feel comfortable. But it's not just about gender using preferred names. What about a young person who has a very long, culturally appropriate name that goes by Joe? We're going to call them Joe. They have, right? Or someone who uses a middle name instead of a first name. And so we have a young kid. My example when we did this training was, so you have a kid who's waking up from anesthetic and you want to make sure that they're okay, that they're waking up okay. And you're saying, Jimmy, wake up, wake up. And they go by James. That's their middle name. I'm saying the same name, but you get what I'm saying. And they're calling the wrong name. So, so it's around safety. It's around respect. It's around creating safe spaces. So it's not just about gender. People make it about gender. They make it really about gender. And then if you offer pubertal suppression, they did a study that said young gender diverse folks who received pubertal suppression compared to those who wanted it but couldn't get it, huge long-term, lifelong improvement in mental health if they had access to pubertal suppression. It decreases potential surgeries in the future if we start this early. It's a reversible therapy, so it's a nice first step. It gives a young person time to explore and figure things out without having to worry about, oh my God, I'm going to start bleeding. Oh my God, my chest's going to grow. Oh my God, I'm going to get an Adam's apple. My voice is going to drop, right? And that's a lot of distress. So how are you supposed to do all those tasks of adolescence and go to school and focus if you're worrying about all these other things, right? So if we can lessen some of that distress, it makes a huge difference. And I asked them after we started, I go, so I know we haven't changed your body, but has this helped with your dysphoria? And many of them say, yeah, just knowing that I'm that much closer to where I want to go has helped. I feel calmer now, or I can do other things. So it's pretty impressive care, and it's not complicated. Same thing with gender affirming hormones. If you look at the folks that got gender affirming hormones in adolescence, and those numbers are small, right? So we had 21,000 participants that ever wanted to have gender affirming hormones. And almost 9,000 of those never accessed them or couldn't for lots of different reasons. And in early adolescence, it was only 0.6%, and late adolescence, 1.7%. Those are hugely small numbers. And that so the psychological distress into adulthood is lessened by access earlier in stages. So the longer we wait, the adage that some parents say, you can do this when you're 18, you can do this when your kid might not live that long at this point, right? So I think it's dire and it's important. All right, what about families? All right, so caregivers come with lots of background and ideas of gender, lots of experiences and things, and they may be struggling with lots of their own issues. A lot of the young people, their parents have gender diverse identities that they hid and closeted themselves for years because they had a bad experience. And then they don't want their kid to go through that. So they're not supportive because it's them, it's not the kid. So really unpacking that's important, and giving that parent space to do that is hugely important. And these fine folks will talk a little bit more about that later, how important that is. They've got fears, they've got concerns, they're worried about what's their kid's future looks like. They have to grieve the loss of what they thought their kid was going to be like, not their kid's not gone, but what they thought that future looked like, they have to rewire that in their heads. And that's their job to do. It's not the young person's job to do that. And then giving them space to process decisions. So we don't make anybody decide anything in the moment. We give reading material, take it away, talk about it, come back later. And then again, encouraging the child's lead. Young kids who are affirmed seldom need counseling because they're happy little kids and they're just being themselves. It's when we don't affirm them that they get into more trouble and need more support later. Why is parental support important? So it's a study that was done in 2014. This is just the mental health slide. But if you can see that the very supportive parents are the dark blue and the somewhat or not are the light blue, and look at the profound difference in depressive symptoms, suicide and suicide behaviors, hugely elevated if they're not affirmed. And an incidental finding of this study was that the somewhat supportive parents and the not at all supportive parents were equally damaging. So this is a parent, oh, I'll take you to that clinic, but I'm not going to use your name and pronouns. Right? So that's not supportive. They're pretending to be, or the kid will say, oh yeah, they're using the right pronouns in front of you, but they never do that at home. Like, I hear that often. And this is not just mental health, it's employment, education, housing, long-term improvement with parental support as adolescents. All right. How do you support parents and caregivers? Like I said, give them some space to articulate those fears. A lot of them are really, really brave in front of their young people, and then you talk to them privately and they fall apart. They're terrified. So give them space to be that. And send them to these fine folks for support groups, all those things. They'll talk more about that. And know that they're not alone. There are other families out there that are like that. It's really important that they can make that connection. And what does it look like for them to be accepting and to celebrate their young person? They're not all going to be marching at the front of the parade, but what does that look like? Can you start with name and pronouns? Can you start with that? I tell young people that they need a pronoun jar. So when they miss pronoun, they get a toonie put in there and the kid gets the money at the end. It's a behavior modification thing like the swear jar. Kids love it, parents don't, but it's a good idea. And so what does it look like for them? So I don't expect all of them to be full on support, but where can we start? Where can we find some common ground? Sometimes I pull my mama card and say, everybody in this room wants this young person to be the happiest, healthy young person they can be. Like, yes, we agree. Okay, so there's some common ground, and where do we go from there? So really important that we do that. Okay. I'm going to plug some resources here from CTOIS, is one of our community partners that we will talk a little bit more about after. So this Families in Transition Guide, downloadable off their website. We give it to all families. It's written by transgender youth and C providers. And it talks about what the young person goes through, but also addresses what the family goes through. So the whole family transition is not just the young person. So you have to acknowledge that as well. Quotes from there. My favorite part of this whole thing is 20 things that trans kids want their parents to know. So here's some quotes. So pronouns really matter. I remember the first time you referred to me in my correct pronouns, it made me so happy and hopeful. Believe in me. When you told me that this is just a phase, it made me stop trusting myself. No parent wants to undermine their kid's sense of self, but we do, incidentally, accidentally. I don't want to lose you. When I can't talk to you about gender, I can't talk to you about my life. That's huge because gender is who they are. It's their identity. You can't just cut that out. I'm going to jump to the last page because I'm not going to read all 22 yet. That keeps some surprises. Show me you're proud of me. I feel like you're ashamed of me when you ask me to hide who I am or to dress differently. Right? You can dress like that here, but you can't wear that to the family function. Your support matters. It changed everything when I felt like you accepted me. I use your support as a springboard to face the rest of my life. Well, that's what parents are supposed to do. So I think it's important to do that. There's other resources out there. This is not, again, not an exhaustive list. Out of San Francisco, there's the Family Acceptance Project. It's interpreted into a bunch of different languages. They have tons of posters and printouts and things on their website as well. So that's a good one as well. Community agencies, there's Central Toronto Youth Services again. Really great. There's so many. When we started our clinic, we had just a small part-time team. We didn't have any funding. We just rearranged our schedules to make this happen. And we just got funding 2 weeks ago from the ministry. So we're going to actually increase our resources and hopefully decrease our wait time. Yay, finally. So yeah, after 9 years of begging and pleading, what's happening. So we've been, yeah, thanks. So we've been very reliant on our community providers because they do really good work. They don't do medical stuff, but they do all the really important heavy lifting, all the social stuff and the psychosocial stuff and the parent support. So lots of different agencies listed there. Sherburne Health has lots of programs. Rainbow Health Ontario, like I said, I do work for them as well. And they are the Ministry of Health funded sort of repository of knowledge and information on LGBTQ health in the province. Really good, again, information resources. They do tons of trainings that are really at nominal fee. And they're all online now because of the pandemics, thankfully. So they used to fly all over the province delivering free trainings, and now they do it online. It's like $40 for a session. So there's a lot of those there. There's the 519 downtown. There's definitely Jewish support stuff at Miles Nadal. Toronto District School Board has a gender-based violence team, and they will go to schools and do education. They will also help you write human rights complaints and do all kinds of supportive things. The Umbrella Mental Health Network is an agency of mental health care providers of all different disciplines who are all LGBTQ identified. So if you need that point of reference, that's also really important. Help Ahead used to be called Mental Health TO. So that's kind of the central number for healthcare in the GTA for folks under 18 rather. So you can call them and they help navigate where the resources are. Kids Help Phone has specific stuff for LGBTQ youth, and Youthline is a peer support, call in and text that's run for LGBTQ youth as well. So there's definitely stuff out there. We have the luxury of a lot of resources in our area, stuff for parental support. Just I was going to talk a little bit more about that in a bit. And there's a great Facebook group called Canadian Parents of Trans Kids. There's about 1,000 members across the country. And a lot of those folks are like academics and researchers. So it's really well moderated. And there's a lot of really good information on there as well. And there's a couple, so there's lots of books out there. So the story is really powerful, right? Getting narratives. So if you want one from a healthcare professional, Dr. Ehrenschaft is a psychologist in California who's like the expert. So yeah, so there's lots of stuff out there. Here's just a sort of page that all the different people that we work with. It takes a village, as we know, and there is no shortage of work for all of us. So I'm happy to refer and help folks out and do all that kind of stuff. It's really important that we do that, particularly solo providers, folks that don't. I have the luxury of a team. I work with endocrinologists and social workers and adolescent medicine specialists. And so, we have groupthink, we can bounce stuff off. We have a difficult case, we can debrief. But if you're a solo provider, it only takes one unsupportive, challenging parent to undermine your confidence and make you stop delivering the care. And there are a number of providers in Ontario that stopped delivering care because of the environment and because of the pushback that they got. So that's really relevant. Okay, real summary, the last slide of the principles. So again, this is a diversity. It's not a pathology. It's an identity that you understand the implications of minority stress, trauma-informed care, gender self-determination. It's whatever an individual says that, respecting names and pronouns, informed consent, the model that we use for care, advocacy where we need to. One, nice phone call to a VP at a school telling them that my patient, i.e. your student, is under unnecessary emotional stress because of the environment in your school. Would you like me to come and do some training? Right? It's important. A little thing with Sick Kids Letterhead goes a long way, right? So still me, but it's Sick Kids Letterhead. Looks important. Those things are, using those positions of power for good and not evil, as I say, and including non-binary folks. Sometimes they get left in the lurch because they don't identify as male or female or somewhere else, and they've been left out a lot. And then working with those families so they can support their young people and building that resilience among the population. And most important point, unpacking your own bias. If something about this doesn't sit right with you, reflect on that. Why is that? Why do I care about someone else's genitals? Why do I care about how they dress? Why do I care about how they present? They're not man enough or woman enough. Why is that?